Good afternoon, ladies and gentlemen. My name is Richard Cruz, and along with Cappy Flanders, I'm the co-chair of the Council on Palliative Care. This lecture is a yearly event. This is the 14th Sandra Goldberg lecture, co-sponsored by the Goldberg family and the Council on Palliative Care. The Council on Palliative Care was formed, I think, 16 years ago, and has as its mission the promotion of palliative care, the provision of educational opportunities to healthcare professionals and members of the lay public in our region and primarily within the McGill community, and serving as an advocate for palliative care on the local, national, and international scene, something which I'm sure all of you realize is a very important function. Welcome to this afternoon. I'm not a McGill graduate, so my experience of this wonderful hall is HMS Pinafore and a few things like that. But I assure you that this afternoon is going to be a lot better. I'd like to ask Neil MacDonald to stand up and offer a few words on the Goldberg family, please.
Thanks very much, Dick. Mary Jane, my wife, and our children were privileged to live across the street from Sandra and Jerry and their family in the town of Mount Royal when we were young. And through that, we became very close friends of the Goldberg family. And then later in life, I was privileged to work with Sandra during her final illness. Sandra was a remarkable mother, wife, daughter, sister, friend. She was blessed with a remarkable wit. I can still remember to this day some of her very apt comments on the events of those particular times. She always seemed to get it right. You're always happy when Sandra entered your life. When she was grown, she returned to her profession as a psychologist, devoted to working with families in distress, dealing with marital issues. And again, her warmth, wit, and common sense enhanced her professional teaching and abilities, and she contributed a lot to the happiness of many, many people. To have a friend be a friend, she would sometimes say, and Sandra's friends were and are legion. During her last days, she died at home. In addition to great family support, a circle of friends was constantly at her bedside. Both Sue Britton and I, Sue was the nurse colleague who was caring for Sandra. I believe that both of us were very moved by the deserved circle of support which Sandra's illness engendered. We think of her to this day, and it is most fitting that her life continues to bless us through this lecture series, which is associated with the visits of 14 of the most distinguished people in palliative care to meet with us, 14 people over the last 14 years. Thank you.
I think it's actually very appropriate that we continue to honor those people who have given us all opportunities to learn, and the Goldberg family has done that. We often tend to forget some people who contribute to events long after they're gone. I now have the very great pleasure of introducing to you Ira Byrock. We're very glad to have Ira come give this lecture for more than one reason. Yvonne Corbet was a central player in the palliative care services in this city for many years and made enormous contributions to that service. And so welcome home, Yvonne. That's the beginning of the introduction to Ira. Ira is a graduate of the University of Colorado. He is a specialist in family medicine and anesthesia and palliative care. He has a long career in the field of palliative care. I'm going to read some things because they've got a lot of names that get me mixed up if I don't read them. I really like to give genuine introductions that come from the heart and not the eyes. But he's director of the Palliative Care Service at Dartmouth-Hitchcock Medical Center. He holds the Dorothy and John Byrne Jr. Distinguished Chair of Palliative Care Medicine at Dartmouth Medical School. He was president of the American Academy of Hospice and Palliative Medicine. For 10 years, 1996 to 2006, he directed the Promoting Excellence in End-of-Life Care, which was a national program of the Robert Wood Johnson Foundation, and I'm sure we all realize how important these flagship activities are, indicating support of organizations that actually help set trends in North America. He's been a consistent advocate for the voice and rights of the incurably ill and their families. He's written extensively. I've got a very large CV here, including books. His real interest is in the promotion of wellness in end of life. And I'm sure that is so true of the people who've come before him in this lectureship, that we're going to learn more about ourselves than we are about anything else as he talks to us. So, Ira, the stage is yours.
Thank you very much. I am the husband of Yvonne Courbet, my claim to fame, and proud of it. It's such a pleasure to be back in Montreal and at McGill. And thank you, Cappy and Dr. Cruz and Neil, for those wonderful remarks. It is just a pleasure to be here. I'm going to try to stay on script because this is being translated, and so if I seem to look down, I tend to extemporize a lot, but I'm going to try to limit that tonight and stay on script. I want to really talk about what I believe is an aspect of our work that is frequently overlooked. At noon today, I gave a talk called The Real Ethics of End-of-Life Care, trying to situate clinical ethics within social and community ethics. And now I want to sort of build on that and explore what I think is really the essence of palliative care, which is love. At professional conferences and educational sessions and in discussion, we tend to focus on technical aspects of clinical care, details of difficult conditions and the intricacies and implications of challenges to our practice, including, in my country, regulations and limited resources and things that often make no sense. Tonight, I'd like to explore the scope of practice, focusing not only on our restraints, but really on expanded opportunities as well as ethical boundaries to our practice. My teaching objectives are these: to locate loving care within a contemporary clinical practice and the ethics of clinical practice, to explore the ethical basis of loving care, as well as potential controversies and dangers of loving care, and to examine tangible examples of and opportunities for loving care in practice. That's quite a bit for a short talk. Why love? Well, love has always been there in clinical practice. It was the initial impetus back in antiquity for healthcare and remains, I believe, the fundamental motivation, the driving force of professional practice today. It's easy to think about primal examples of love in human caring. We don't have to look far. Motherly love is the essence or the most profound elemental aspect of human caring. A mother's love for her child is unconditional, unbounded, natural, inevitable. It is a force in the world, an essential ingredient in normal human development. Absent mother's love, children do not thrive. In fact, they can wither. Correspondingly, the love of an infant for her or his mother is absolute, total, unbounded. There are other examples. For many people of faith, God's love represents the pinnacle of supreme, unconditional love. People of faith express feeling cared for by God, even in the midst of terrible physical illness and misfortune. And then, of course, we have the love of a pet for his or her owner. And, of course, the love of an owner for his or her pet. This is unconditional love. In the United States, it's often said that if a politician in Washington craves unconditional love, he should get himself a dog. Our spiritual coordinator at the palliative care program at Dartmouth, which I am part of and help direct, Chaplain Linda Piotrowski has said, only half-kiddingly, that she is not sure it is entirely a coincidence that the word dog is an anagram for God. It is my sense that the ideal of selfless, unconditional love does come from the faith traditions. It comes from Buddhism, of all things, which is often thought to be a cold and insensate or unsentimental religious discipline. But in Buddhism, love is epitomized by the Bodhisattva. Having achieved utter enlightenment, the Bodhisattva could rest within the perfect peace of nirvana, pure equanimity. But instead, the Bodhisattva chooses to stay engaged in the world with all its imperfections, in service to others, because there is no pure peace while other beings suffer. The Bodhisattva's statement, may all beings be free from pain, may all beings be free from suffering, may all beings know joy and happiness, may all beings become enlightened. To those who look at Buddhism as cold and unfeeling, the question that I would pose is, why did the Buddha teach? The basis, the primal motivation was love. Love is the primal motivation of all human caring. It's natural, it's wholesome. We wouldn't be the same without it. In our contemporary context, again, I speak as an American, but I know quite a bit about and am learning from Canadian healthcare, as many Americans are. Both the good and the bad, by the way. And I know that the contemporary practice, the context in which we practice is challenged often. So to try to locate the rationale and role of loving care, we need to look at that context of practice. Indeed, the scope of clinical care, for those of us in the United States certainly, is really constrained. Mostly we're constrained by busyness, by pressure of production, by too many people to see in too short a time. Demands of committees and education and all the other things that compete for service, our time rather, and for our services as clinicians in academic centers, certainly. Other constraining pressures are less obvious, and I want to point to three aspects of clinical practice that are not often seen as constraining, but as good as they are, they also have constraining influences. First is clinical ethics, the second is problem-based medicine, and the third is evidence-based medicine. Together, they limit our ability to perceive and therefore respond to a full range of human experiences or to make use of a full range of human responses to the distress and suffering we encounter in clinical care. Let me unpack that. Here is the principle-based model of medicine. For those of you at noon, I briefly introduced this. This is the way clinical ethics is usually taught, at least at the undergraduate level. Preservation of life and alleviation of suffering are jointly the beneficence dictum, that we must do good for our patients. Non-maleficence is captured by the Latin phrase primum non nocere, first do no harm. At very least, we should not add to the distress of people. Autonomy is often misstated as the right of people to do what they will with their bodies. Not quite. It's actually, at least in the United States and in ethical white papers and court decisions, seen as people's right to choose between indicated options of treatment that are offered to them and to refuse any treatment that they wish to refuse. And the courts have said people don't even have to share their rationale for refusal to clinicians. They only have to give evidence that they are able to understand and process the information and to come to a decision, a considered decision that is somewhat consistent over time. Distributive justice, what we're struggling with in the United States, where there are 46 million uninsured people. The notion that at least the basic elements of health care should be available to all, regardless of their age, their gender, their sexual orientation, their diagnosis, the language that they speak, the color of their skin, their religion or lack of religion, where they were born, all of that. That at least the basics of health care should be available to all. And then truth-telling, the notion that people have a right to the information available to them about their treatment, their condition and treatment options, and in words that they can understand. And then there is the integrity of the healthcare professionals, often left off of this principle-based list, but important that professionals, those of us who are licensed clinical professionals, have certain authorities and powers that are given to us by society. But we also have firm restraints and constraints that we can't decide on any given day what seems ethical to us, that we have to test what we believe is ethical practice against the boundaries of our professions that are developed over time. And that's an important aspect, because you get to situations like this. It's a tough day at the hospice. My dying wish is that you all take off your clothes and get in bed with me. Well, it's his right, isn't it? I mean, the man, he's dying after all. No, of course, there are always two moral agents in any clinical encounter. It's silly, but the point is a serious one. People may want many things from us, but our ethical standards and guidelines define both our responsibilities to them and the boundaries of our professional roles. Indeed, there are always more than one ethical principle that apply in any real-world clinical situation, and usually more than one stakeholder, family member, others, even clinicians, whose perspective and stake in the situation needs to be held in tension and brought into balance. End-of-life care is not a place where strict constructionists are likely to feel comfortable. Indeed, the struggle we go through within ourselves and within our teams is, I believe, what imbues our clinical practice with its ethical authenticity. You cannot remove that struggle from difficult clinical situations and retain ethical authenticity. It's part and parcel of it. We're more than algorithms and protocols. And indeed, though our intentions need to be good, we are likely to struggle. Now, clinical ethics is an important field, clearly, that we all rely on and learn from. Clinicians, we are who we are partly because of clinical ethics, and it's extremely valuable. Clinical ethics as a discipline really grew up in some regards in parallel with palliative care. They both started as almost countercultural responses to people dying badly, often in hospitals, often alone. The early history of bioethics has been marked predominantly by subtractive themes. We have defined over time things like the right to refuse unwanted treatments that I mentioned through the principle of non-maleficence and autonomy. We've defined when people can refuse, CPR, when they can refuse ventilation, when they can even refuse medically administered nutrition and hydration. In fact, these subtractive themes are based on individuality, and in my country that's sort of a Jeffersonian construct that works really well in the body politic, but I'm not so sure it works entirely well in the biology and the world of social ethics. Defined by autonomy, defined by protection from dangerous circumstances. We've explored through clinical ethics the notion of futility, when things are absolutely useless and can be withheld or withdrawn. Notice that clinical ethics is, we've developed things like advanced directives, which are written in contractual language. Dr. Joseph Finns from Cornell has pointed out that this contractual language occurs when there are perceived dangers in the future. And it's there to protect oneself from a dangerous environment where you have somebody to look after you. These subtractive themes emphasize protection. And they have, if you follow those subtractive themes, you get to these sorts of situations. He says, just so you know, I never want to live in a vegetative state dependent on some machine. If that ever happens, just unplug me, okay? Okay. I suggest that there's an alternative that complements the subtractive themes in early bioethics that need to be explored to look at the full range of the human responses, clinical caring responses to difficult life situations. In fact, to really complement this early theme, we need to look at additive or expansive themes in ethics, which I would submit, and I'll leave you to consider for yourself, a counterbalance. Instead of individuality, we have mutuality. You know, beneficence already counterbalances non-maleficence and maybe even autonomy. We'll explore that. And then there's trust. And again, Joe Finns had an insight that while we develop these advanced directives in contractual language, in reality, and he and I and a research group did some research to prove this, in reality, people actually want decisions made in a covenantal fashion. They appoint people they trust. And instead of constraining people to make decisions just how they wrote it in their living will, if you actually provide people with scenarios that challenge the a priori constraints of their advanced directive and say, if your own proxy were to make a decision to eventually take you off of the ventilator, even though your advanced directive said you never wanted to withdraw any treatments, would you feel betrayed? And vice versa. You know, we provided lots of different scenarios. The overwhelming majority of people said no. I trust the person to make the best decision possible on my behalf. Indeed, let me suggest just as an introduction that loving care represents the epitome or clearest example of these expansive or additive themes and would expand the conceptual framework of clinical ethics in a manner that would balance these early subtractive themes. And I'll return to that point in a moment. A second theme that has had a constraining influence on our scope of clinical practice is problem-oriented medicine. We all practice problem-oriented medicine. In fact, despite its shortcomings, I'm actually quite a fan of problem-oriented medicine. It began, many of you will remember, in the 1970s. It was the work of Professor Larry Weed at the University of Vermont, who developed the problem-oriented medical record. It was a brilliant advance in medicine. Prior to the problem-oriented medical record, or what's often called the POMR, it was very difficult to discern what the previous physicians seeing a patient had been thinking, what their analysis was, and really what their plans of care were. After the POMR, the problem-oriented medical record, you could begin to discern and build on what happened prior in diagnostics and analysis and therapeutics. So these days we teach all of our students to first start a problem list when they meet a new patient, and then for every problem under that list to soap their notes. You guys talk about that up here? Every problem under a list, you develop subjective information, objective information, create an assessment and a plan. That's all well and good, but it's limiting because it constrains us to thinking within a conceptual framework of medicine that is problem-oriented. Woe be it to the intern or resident who orders a test that doesn't directly relate to a problem on the list. Heaven forbid they were to start a therapeutic intervention that didn't respond to a problem on the list. Now the model works well in dealing with problems. We use it all the time. But it's limiting. In fact, the experience of people living with advanced, ultimately life-limiting illness is first and foremost not constrained by problems. You know, their illness and their dying are not fundamentally medical, they're fundamentally personal. And if all we see is a problem, and if all we can respond to are problems, well, that's limiting. And then, of course, there is evidence-based medicine, something which we all celebrate, rightly so. It is an essential advance in the science and the practice of medicine and being able to translate science to practice. Those of you who are not familiar, and I'd be a little bit surprised if any clinicians are not familiar with these sorts of definitions, evidence-based medicine has been defined thusly: as the conscientious and judicious use of current best evidence in making clinical decisions. Well enough. Hard to argue with. Evidence-based medicine de-emphasizes intuition, unsystemic clinical experience, and pathophysiologic rationale as sufficient grounds for clinical decision-making, and stresses the examination of evidence based from clinical research. And, of course, the gold standard would be the randomized clinical trial research. Once we have, it's an important tool for refining what we know and being able to move clinical therapeutics forward. But it can have unintended consequences. For not uncommonly, we have begun to look toward the evidence to define the scope of practice. In fact, if I were to start a therapeutic intervention with somebody, maybe it is some of the complementary therapies or life review. If part of a team doesn't want to do it, what do they ask? You know, where's the evidence base for that? Right? It's one of the things that we tend, if there's not a randomized clinical trial, we're not sure it's real. Once we have defined the scope and goals of care, evidence-based medicine is a very powerful tool for advancing toward those goals. But it was never designed to define the scope of clinical practice. And in so doing, it's misapplied. By extension, the constraints on our scope of practice can influence our cultural understanding, expectations, and norms for human interaction with people experiencing illness, people caregiving, and the human experiences of dying and of grief. But as I asserted at the beginning of this presentation, the fundamental basis of medicine is in fact not science. Science is a tool for advancing medical goals. The fundamental basis of medicine, the primal impulse, is love. Problem-based medicine, problem-oriented medicine, and subtractive themes in clinical ethics have a real impact on healthcare. They have contributed in mutually reinforcing ways, as I mentioned, to constricting our practice. And they've had important constraints on our social and cultural view of this time of human life. Now, I have to turn attention to the topics of physician-assisted suicide and euthanasia. For, in fact, in one sense, they are the logical extension of subtractive themes in clinical ethics. We have defined when it's ethically acceptable to take away CPR or withhold it, to withhold surgery, even to withhold antibiotics, medically administered nutrition and hydration. And ultimately, if someone is suffering, the assertion is made that there must be some circumstances in which it is ethically legitimate to take away life itself. These preempted, deliberate deaths can seem merciful given the constricted prevailing clinical and ethical framework. When suffering is severe and persistent, and none of our potions and protocols seem to work, when it appears that suffering is capturing every thread of a person's existence, there can seem to be nothing left to do. We cannot imagine anything left to do. Thus, advocates for legalizing physician-assisted suicide say that the lethal act is a new medical service that responds to the demands of suffering patients sometimes, and is a compassionate response to persistent suffering. Indeed, in certain circumstances, suffering, preempting death can seem beneficent, as well as an extension of people's personal autonomy. In fact, one of our colleagues and one of my mentors, Robert Twycross, has said, "A doctor who has never been tempted to kill a patient probably has had limited clinical experience or is not able to empathize with those who suffer." However, my response to this, those of us who work in this field would say, that is why we work in teams. That is why we have standards, professional standards, to remind us that there are boundaries to what we do. I don't want to in any way diminish or in any way denigrate those who promote and advocate for legalizing physician-assisted suicide. I think they do so out of good feeling and compassion. But there are constraints that if we begin to erode the very basis of human caring and clinical medicine. Indeed, while beneficence encompasses any caring intervention, including palliative sedation for otherwise uncontrolled, intractable symptoms, it does not encompass eliminating the sufferer. Alleviating suffering by any means necessary is distinct, importantly different from eliminating the sufferer. Whether or not death is to be considered in a person's best interests, by even the person himself or herself, it is not part of the nature of medical care. Indeed, if you look up the verb to care in the dictionary, it's defined as to take charge of, to look after, to provide for. Notice that within the very definition of the verb to care, there is a longitudinal dimension. It extends into an open-ended future. So, again, not wanting to diminish the seriousness and the good faith of people who are advancing legalizing assisted suicide, I stand to think that there is another alternative, and that our imagination has been constrained by early bioethics and by the problem-based model and by the current evidence base of medicine. What it leaves us with as clinicians is the situation in which we have someone in front of us who is suffering, and we cannot imagine another way to respond. Perhaps the limitation is not in our therapeutic capacities, but literally in our imagination. There is plenty of precedent for love in human caring. I quoted this famous quote this afternoon, and I would guess most of you are familiar with it, by Dr. Francis Peabody, a surgeon at Harvard from 1927. One of the essential qualities of the clinician, he said, is interest in humanity, for the secret of the care of the patient is in caring for the patient. This quote was picked up and extended by Engelbert Dunphy, who was one of the premier surgeons in the United States in the 20th century. He was chief of surgery at University of California, San Francisco. In an article that he wrote in the New England Journal in 1976, He said, Francis Peabody's dictum permeated our student days at Harvard. We learned that the practice of medicine is cold and abrasive unless tempered by love. Quite a statement from the head of surgery. Indeed, love is part of healthcare, whether we acknowledge it and name it or not. Dr. Avitas Donabidian is rightly credited with bringing quality improvement, the CQI or TQI model, total quality improvement or continuous quality improvement, back to medicine, back to the United States, in fact. This was the Deming model of continuous quality improvement that had been actually developed in the United States, exported to Japan to manufacturing, and then re-imported by Dr. Donabidian. He gave us this structure, process, outcome model of quality improvement in healthcare, which we still use today. He said, back in 1988, we need detailed information about the causal linkages among the structural attributes of the settings in which care occurs, the processes of care, and the outcomes of care. This is key still to quality improvement today. And then, when he was in fact himself living with and dying of advanced prostate cancer, Dr. Donabidian was interviewed by Dr. Fitzhugh Mullen for Health Affairs. And then he said, systems awareness and systems design are important for health professionals, but are not enough. They are enabling mechanisms. It is the ethical dimension of individuals that is essential to a system's success. He said, ultimately, the secret of quality is love. You have to love your patient. You have to love your profession. He added, you have to love your God. If you have love, then you can work backward to monitor and improve the system. Now, there are actually mainstream examples of love in mainstream medicine. They are most obvious, if you will, and evident, so evident that we hardly notice it, in that mainstream branch of medicine called pediatrics. Right? I've practiced a fair amount of pediatrics in my earlier years. I was trained as a family doc. I actually practiced emergency medicine and became board certified in emergency medicine for years, worked in a hospital that saw many, many children. When a child is crying in the emergency department where I used to work, what do people do? They don't look at the child and say, well, I think that kid needs some more morphine. Not the first thing that comes to mind. If you just witness what people do, they go over, they pick the child up, they check the diaper, they put a bottle in the child's mouth unless the child is NPO for some reason. But also they unabashedly love the child. I don't mean in a philosophical or new agey kind of, oh, we love our patients. No, they pick the child up and hug and caress and coo and play with the child. And it's seen as utterly natural. It's not seen as in any way unseemly. It's just what we do. It's reflexive. We can hardly keep from doing it. It's so pervasive we don't even notice it. Parents, families, clinicians, even passers-by do it. And it's normal, natural. It would be odd not to. And yet, it seems odd often to talk about doing it with adults, even elderly people. Touching children who are suffering and adults who are suffering in these manners with the intention of eliciting comfort and even eliciting pleasure can be entirely wholesome. And yet these days it raises concerns. I'm not often asked to give this talk, by the way. Talking about love in the context of a medical conference can make clinicians in the audience begin to squirm. Whew! Did you hear what he said? He loves his patients. It seems unseemly. I think, frankly, it calls up like sexual connotations. How bizarre is that? Really? Indeed, while we're going to talk about some of the ethical controversies and potential dangers of loving care, let me just assert, I think it's wholesome. It's okay. Indeed, loving care represents a realm of therapeutic possibilities that are foreclosed by the problem-oriented approach to therapeutics. When suffering persists despite proper use of our clinical protocols and our pharmacologic tools, loving care provides clinicians with tangible things to do. If nothing else, that can diminish a clinician's own frustration. And that's not trivial. As clinicians, our frustrations can result in actions or inactions which affect the patients and families we're there to serve. Problems of commission and problems of omission in what we do. In this manner, at least, this notion of loving care and opening realms of practice and things to do represents an antidote to therapeutic paralysis that can result when clinicians are feeling themselves helpless, impotent, and unable to imagine anything else they might do for a suffering person. Indeed, Pediatrics provides us with one of the mainstream precedents for loving care. But there are other precedents. In fact, the other one is from the early history of hospice and palliative care. Palliative care, growing from a hospice base, always has chafed at the problem-oriented model. So has, by the way, pediatrics. It never knew what to do with things like, with things like health maintenance. Is that a problem? How about preserving opportunity to grow and develop and be all that he or she can be? How do you make that a problem? Unless you're worried about failure to thrive syndrome. That's the problem, right? But optimizing well-being? Similarly, in hospice care, we knew that a lot of what we did was not solely tied to responding to human problems, that there was something else there. Indeed, Sandra Goldberg, who wrote one of the very first histories or overviews of hospice care in the United States, look at the descriptors that she used to introduce people to hospice care, to describe it. She used descriptors like hospice care as a model of care that is where people are cherished and refreshed. It is a special type of care where people are honored. Hospice is a place of welcome, whether it's a physical environment or not, a loving environment. Hospice care is not mere technique. It is a gift and an offering of the best that we have in our minds and in our hearts, right from Dame Cicely Saunders' description, from David Tasma's request to her, I want the best of your mind and your heart. Hospice is an intimate transaction between human beings in community. Absolutely correct. So, what do we mean by this? I've talked around it a bit. What's it look like? Here's my working definition, which, by the way, changes from time to time, so this is the best I know today. I would define loving care as direct care intended to convey positive regard, improve comfort, and enhance quality of life. Loving care may be provided to alleviate distress, promote a sense of well-being, evoke pleasure, or foster personal connections to others. That's a dry definition, though. The best way I can describe it is by introducing you to a few patients. Phyllis, an alias, all of these are aliases, was only 39 and struggling with esophageal cancer that had eroded through her trachea, causing recurrent mediastinitis. It would have been easy for the healthcare team caring for Phyllis, including our consulting palliative care service, to focus solely on her pain and multiple medical problems, her multiple medications needed to control her pain and her feeding problems and everything else. Very easy to focus on her very troubled social situation. Along with some remarkable nurses on the oncology floor at Dartmouth-Hitchcock, our team focused on Phyllis as a whole person. And she was a remarkable person with style. She was a delightful, engaging, fun-loving individual. She grew up in New Jersey, and since I did too, we had a little bit of a immediate connection. She described herself, she was a self-proclaimed biker chick. During the 1970s and maybe into the 1980s, she had been a groupie for some national rock and roll bands, and she was proud of it. She had had a flamboyant past, talked to us about the major bands and rock artists she had slept with. And there were several. There were only a few friends. She had only a few friends. She had never really stayed in one place for a long period of time as an adult. There were not many people to step forward to care for her. Nobody who could care for her full time. And in addition to the medical and nursing care that she needed, we worked hard to meet her needs, but also to listen to her stories and to celebrate her as a person and to unabashedly show our love for her, our affection for her. On the day that she was discharged to a very fine inpatient hospice facility in our region, here we took a picture of her. Actually, Yvonne took this picture with Phyllis wrapped in a prayer shawl that one of our nursing colleagues had knitted for her. It symbolized, at least for me, I think for all of us, the love that we wrapped Phyllis in our care. A very different fellow is, I'll call Robert, also an alias. Robert was 58 years old, had long-standing end-stage renal disease from glomerulonephritis. He was also a vasculopath, had bad peripheral vascular disease. He had hemodialysis 3 times a week in a rural dialysis unit up in northern New Hampshire. He came to the emergency department one day with pain in his groin, and while he was in the emergency department, a previous aortofemoral bypass surgery ruptured, and he darn near exsanguinated in the emergency department. But you don't die of something like that in the Dartmouth ER. Not okay. So they resuscitated him, took him to emergency surgery. They had to amputate one of his legs. When I met him, he had been in the ICU for some time with an ischemic left leg remaining, and he was delirious, difficult to know what to do with him. When the ICU doc called us up, he said, "I have a patient here I really need you guys' help with. He's an unbefriended patient who is seriously ill. We need to figure out what to do. We think, he really needs to have his other leg amputated. He can't give us permission, and when he is even a little bit lucid, we can't get anything from him, and we don't know how to make this decision and who to ask." We were told he had no friends or family, no legal surrogates. He had no advance directive on file, even though he had been getting dialysis for years, and we were asked to help clarify decisions. Okay. So we saw him there. The surgical team was uncertain what to do, and we helped. Because Robert had always wanted everything done, hemodialysis was continued. His resuscitation status remained full code, full CPR. Everybody was stymied. We took care of his pain. We worked hard, including using doses of ketamine during dressing changes to his open wound in his groin, and propofol sedation. Gradually, things got better. Over a few days, things got better. He wasn't obviously suffering. Gradually, fortunately, his mental status began to clear a bit, and we were able to communicate with him. Try as we might, however, he continued to evade, really, seriously avoid any conversation about surgery for his remaining leg. Wouldn't talk about it. Kept changing the subject. I personally spent hours and hours in the ICU trying to coax a decision out of Robert. I said it was okay if you don't want to have it done, but understand if you don't have it done, you're going to die of gangrene. And that's not, that's okay if that's what you want to do, but it's important that you know that that's what's going to happen. And if you don't want surgery, then we shouldn't probably do CPR. We should, make you a DNR, or do not resuscitate. He wouldn't talk to me about it. It turned out, in digging further, that he actually had a sister who lived out of state. It took a lot of digging. With his permission, I contacted his sister and got her on the phone. In the ICU, fully gowned because he was in isolation, he had MRSA, I probably forgot to mention. I brokered a conversation between Robert and his sister Jane in Illinois, going back and forth with the phone on a long cord in his room in the ICU. I was trying to get Jane to help me get a decision from Robert. After several, probably 20 or 30 minutes going back and forth, he was happy, by the way, to talk with her. She was happy to talk to him. They hadn't spoken in years, but loved one another, was really nice. Okay. Finally, when I explained to her what the situation was and what the decision to be made was, and I said, Robert, you just got to give us a decision one way or the other. We'll do whatever you want to do. He finally looked up at me and said, okay, all right, cut it off. I said, okay, Robert, we'll get you to surgery immediately. By that time, the leg was, ischemic enough that was going to happen that afternoon. I said, do you have anything else to say to Jane before we hang up? He said, nah. I held the phone. I said, maybe you want to tell her thank you? He said, oh, all right, yeah, that's good. So I handed him the phone. He said, thank you. I said, hold on, Polly. I think he's got something else to say. I handed the phone back. I said, do you have anything else to say? Oh, she had said, I forgot to say, she said, you're welcome, Robert. That's really wonderful. Anything else to say? He looked at me and said, I don't know. I said, do you want to tell her you love her? He said, oh, yeah, all right. Handed him back the phone. He said, I love you. Okay. I said, Jane, did you hear that? She said, no, I couldn't hear. What did he say? I said, try again, Robert. He said, I love you. She says to me, did he say I love you? I said, yep, that's what he said. And she started to cry and she said, oh my, tell him I love him too. Did you hear that, Robert? Yeah, okay, great. That was it. He went to surgery. This is several days after surgery. He never got out of the hospital. He ended up finally dying in the hospital after a long period of time. But he did get out into the corridor with sunshine filtered through light. He had some very good weeks. He did not die unbefriended. He died, frankly, surrounded by love. And lastly, Mrs. Gold. Mrs. Gold was a 78-year-old woman who I met in the ICU. She had always taken good care of herself as well as others. She had raised 4 daughters and 2 sons. When at 38 years of age, her husband suddenly died, she went back to college and studied nursing. She became an obstetrics nurse and worked in that capacity until she was nearly 70. Before a chest cold tipped her breathing over the edge, Mrs. Gold had been living independently in a senior complex, using oxygen at night for her COPD and pulmonary hypertension. When the cold became worse and she ultimately had pneumonia, she reluctantly came to the emergency department and was admitted to the hospital for IV antibiotics. During the first 2 days in the hospital, things got better, and then abruptly worse, and she was moved to the ICU. Our palliative care team was asked to see her to help with comfort, but also to clarify goals of care. When I met Mrs. Gold, she had been in the hospital for 9 days and in the ICU for 6 days, and a victim of, as I said, pulmonary hypertension. Now she needed mechanical ventilation if she was going to get better, but she steadfastly refused any notion of it. Instead, she was fitted with a BiPAP mask that she initially wore most of the day, but not 24 hours a day. She could speak in short, well-planned sentences if the BiPAP was removed for a few moments, but mostly she communicated expressively with her hands and her eyes, and there was really little difficulty of her expressing her wishes and mostly her thoughts. She had no problem conveying to us that she was not happy. She told us in one breath, I don't want to live like this. She was getting tired, and there was still some small chance that she might improve. The critical care and pulmonary teams and her family all negotiated for a few more days. Give us a few more days, they said. And she said reluctantly, okay. After a few days, she was only a little better, but she was dependent on BiPAP for over 12 hours per day. She told us she was not afraid of dying, but she didn't want to feel breathless and gasping, as she had often in the past, in the last several days even, while she was in the hospital. Very small amounts of opioids, morphine, were used to help alleviate her anxiety and breathlessness, and mostly she grew to trust us that we would not let her suffer. Her children and her spouses and all of her grandchildren were less accepting of her fate than we were, or she was. It wasn't conflict, they were just aching with grief at the thought of losing her. During one of several meetings with her family in the ICU conference room, a daughter in her 40s spoke for the assembled brothers and sisters and grandchildren. She said, "We're as close as any family could ever hope to be, Dr. Byrock." Despite her own suffering, Mrs. Gold was well aware that she was the matriarch of her family, and she spoke with her children and told them that it was time for her to be allowed to die. They needed only a little guidance from us to know what to do and say. Through her tears, and the children and their spouses told Mrs. Gold that she loved them. Gradually, over a period of really just 36 hours or so, her ICU room was just transformed into family space. There were at least 30 photos of her hung around her ICU glass room, including one of her own mother in a frame as a bride, her mother as a bride with a long train, one of those classic photographs. She was never alone. Usually there were 2 or more family members present. Her pastor visited her every other day. As another day passed, Mrs. Gold became tired, was dependent on BiPAP essentially around the clock. We made sure she knew that the timing of any withdrawal of the BiPAP was up to her. She had reminded her son-in-law, who's an accountant, about a few details that needed to be tended to in her fiscal life. She said she was ready to discontinue BiPAP and ready to die when her children were ready. So we worked and supported her children and their spouses and grandchildren. They told stories about her. They continued to gather. The night nurse said that she would intermittently hear crying and peals of laughter from the ICU room. They had meals at her bedside. Mrs. Gold's family essentially waked her out of life. I happened to be present. It was a Saturday, and I had 3 Dartmouth medical students with me on my rounds when Mrs. Gold had made the decision with her family that this was the time that they would remove BiPAP. We had given her, again, reasonably small doses of morphine and some lorazepam to diminish her discomfort. She was sleepy but awake. There was never a hint of distress. As she died, the last thing that Mrs. Gold saw in this world, the last thing she heard and felt, were the faces of her 6 children and 2 of her grandchildren, each touching a part of her body, each smiling through tears in their eyes, each saying things like, "We love you, Mom." One said, "Tell Dad we send our love. We'll see you again soon." It was all that I could hope for Mrs. Gold and her family. I was frankly transfixed by the experience. Once again, I felt the privilege of witnessing this intimate event in people's lives. It's such a precious privilege. These sorts of gentle, loving, end-of-life experiences happen fairly commonly in the homes of hospice patients. This is the stuff that fills hospice books and brochures, doesn't it? And yet, in reflecting, here we were bringing this into the ICU. Not too long ago, critical care and hospice care were seen as polar opposites. Here we're proving in practice that they work well together, proving it to the 3 medical students, with me, seeing that this is the best care possible. And as I begin to close here, here's another patient, a quick one. Harry was dying of a terrible transitional cell carcinoma. He had had a pelvic exenteration, and yet despite all that, he wasn't going to get out of the hospital alive. When I asked Harry, "Is there anything left undone in your life?" he looked at me and said, "Yeah, I gotta marry Darlene." They had been sweethearts for 14 years, but had lived separately in their own houses because of finances and work, and they never could get it together to combine their households and formally get married. So we did that. With our help, Harry was able to give a bouquet to Darlene. With the help of the chaplains and nursing staff, we created a ceremony and had a celebration. Here are students, by the way, not on their hospice or palliative care rotation, but on their surgical rotation, learning that sometimes the best care possible in surgery includes the marriage of a patient and his loved one. Isn't that something? It expands the realm of what we're able to do to respond to human needs and human suffering. Ah, Joanne, her real name, I say this with permission. Joanne also, a nasty colon carcinoma, also had a pelvic exenteration in the hopes of finally getting her to be cured. It wasn't to happen. Every time they did surgery, margins were positive and finally distant mets were found. The morning that, this is an afternoon picture, the morning that this picture was taken, we had had a long session at her bedside. She had just been told that the latest surgical margins were positive and that there was no cure. She, at this point, because of the surgical attempts, had open wounds and vac dressings and multiple drains, and she lived in a rural area with her husband. There was no way we could get her home, which, of course, is what she wanted most. There was just no way. We're pretty creative, but we couldn't do it. So we had to give her that news. She took it hard. It was a long, poignant meeting at her bedside. Before we left her bedside, after at least an hour, we asked her what I often ask people on rounds before I leave their room. Is there anything else we can do to just brighten your day today? She looked up and said, yeah, I'd like a daiquiri. Well, we can do that. There's a lot of stuff we can't do, but yeah, we can do that. So here are my colleagues, Dr. Marie Bakaitis and Dr. Fran Brokaw. They assured me that their daiquiris were virginal, but Joanne's wasn't. We had made a quick trip across the highway to get to a liquor store, and that much we could do. She died surrounded by love. Okay, nice enough. But there are potential controversies, of course. There's this from Doctors Without Boundaries. So, could we have all of your stuff after you die? They said. It's funny, of course, we would never say anything like that. We leave that to our development offices. Ooh. But I bet you can think of a colleague or two or a volunteer who tends to get enmeshed with patients and families. They're loving people, but there is something clingy or needy about their interactions, and that isn't wholesome. We have professional boundaries because we are supposed to be in service of other people. It's all about them. It's not about us. And people are vulnerable and ought to be able to be vulnerable in our presence. So there should be no manipulation or need to satisfy our own needs in service of others. Right? Again, Doctors Without Borders. You're the picture of health, and by the way, I'm totally in love with you. We know of, I know of a couple of couples who, where a hospice nurse had married the widower of a hospice patient. I think one needs to look at that very carefully. There are potential for real misdeeds there, and that may be wholesome, but it may not be wholesome. And then, any of you are a fan of Gabriel Byrne's character in Treatment, an HBO series. Doctors are prohibited from having sexual relations with patients. Of course they are. This boundary is essential to preserving the safety that enables patients to become utterly vulnerable in our presence. It's built into the fabric, the architecture of the profession of medicine. Erode that boundary and the architecture of the profession begins to dissolve. Gabriel Byrne, as psychoanalyst Paul Weston has a problem with getting a little too close to patients. In a series, I think last year or the year before, he fell in love with his patient, Laura. And in fact, although she was the one who initiated the intimacy, yearned for it, she argued with him for it, his behavior in acquiescing to her desire for intimacy crossed the line. It was wrong. And if you tell me that they became married and I met them 25 years ago, I would say, great, that's wonderful, but it was still wrong. It crossed a boundary that is important that we preserve. Not all love is the same, of course. There are different types of love. Let's be honest, not all love is pure. If we had more time, if this was a semester or a workshop, we could break up into groups and interact as a small group as a whole and explore some of the different qualities of love. I've just suggested them here. Somehow this box got lost in conversion from Mac to PC, but you know, look at the difference of all of these categorical types of or qualities or characteristics of human love. In romantic love, we may be able to, you see the scale over here from 1 to 4. How much is there well-wishing? How personal is it? How exclusive is it? Possessive? Are there expectations? How much of love has a characteristic of longing associated with it? How much is it mutual and expecting to be returned? Selfless, physical, sexual? How about the love of a mother for a child? You would grade these differently than romantic love. Not all love is the same, right? There's filial love, brotherly love, the love of oneself, the neighborly love for a person, even a child, neighborly love for an elder, fatherly love. We know that father's love and mother's love are different. You've read Erich Fromm, right? There's more expectation in father's love, we're told. We could go on and on. I talked about the love of a child for a parent, where there are some expectations and mutuality, some possessiveness. There's the love of a pet, a beloved pet. Then there's the love of self. Notice how there's different qualities to each of these types of human love. There's agape, or universal love, which is not possessive, I don't think, not exclusive, obviously, because it's universal. We think it's selfless. But where we want to get to, of course, is this, the love of a patient. It's a young girl with cystic fibrosis who I came to love. You get a sense of the difference. It's not possessive, at least it wasn't for me. I don't know if it was mutual, I think so. But it wasn't an expectation, it wasn't necessary. It certainly wasn't sexual. It was physical in some regards because I was concerned about her comfort and well-being. We could go on, but you get a sense. There are limits to love. There are some people who it would be very hard to love, right? This gentleman's a prisoner from a violent crime. I know that working in emergency departments, it's not easy to love all of the patients coming in. I've taken care of patients who were covered in tattoos, including swastikas, who were swearing at me. It challenges us. And there will be some people who we may not be able to love. But that, I say that because in the work that we do in end-of-life care, sometimes we meet people who we were told were nasty, we knew were nasty people earlier. And in prison hospice work, this happens frequently. We meet people who had perpetrated terrible, violent crimes, even hate crimes, and yet when we meet them, they don't seem hateful. Indeed, I would assert that sometimes innocence that has been lost can be regained. I say that to provoke your thought on this issue. Because usually we think of innocence, we think of children. They're utterly innocent, right? They have no experience. Experience brings responsibility. You have a track record. Things go on your permanent record, right? we have this notion of innocence like this, that we have it when we're an infant, and then over life it gradually diminishes. For some of us, more quickly than others. Right? But is that really true? I remember a gentleman, when I was the medical director of a hospice program, we had a residential hospice program, and a gentleman named Jacques was one of those. He seemed to be living in another time. He was a little bit fuzzy, and he had at least early dementia, which was not why he was in the hospice program. He also had a lung cancer. He would never say what year he thought it was, and it was difficult for us to gauge his level of cognitive deficit. He knew he was old and that he was approaching the end of his days, but he was either just demented enough or emotionally unwilling to deal with the hard decisions that he had, and he deflected questions. And he usually launched into a story or a song. He told the nurses and me stories of being a soldier in France, some of which were funny. He sang French songs from the era. He sang Frère Jacques and Mademoiselle from Armentières, and he really entertained a lot of people. When I talked to his primary physician of many years, the physician told me this guy is not a nice guy. That he had been an abusive individual to coworkers and to his wife of many years, very judgmental. But when we met him, he seemed utterly innocent. You know, he had qualities of being undefended, of being vulnerable, of being utterly gentle and warm, that I think define for me the characteristics or the qualities of innocence. So it's just possible that our conceptual framework of innocence needs to be challenged, that perhaps innocence is one of those qualities that actually can be reacquired at the end of life as other aspects of people's personhood change. It's been useful to me to think in these terms as I care for people who I know in the past I probably would not have had much affinity for. So again, what do we know about the practice of loving care? For me, the examples of loving care have come, frankly, mostly from nurses. In fact, nursing models of care, for me, exemplify loving care. Here's a quote from a hospice medical director from a few years ago. Quote, "I get much of my inspiration from the nurses' aides to do the primary care where we have a beautiful spa bath in our hospice. They love to take people in there and give them whirlpool baths, do their hair and nails. A long time ago, I heard that much of the trouble in the world is caused by tone of voice. I think that's how much of loving care is given in hospice, is the gentleness. As you mentioned, like pediatrics, the gentle tone of voice that is used. Several years ago, I interviewed an old hospice nurse. Boy, she'd hate me to describe her like that. An experienced hospice nurse named Kathy Kalina from Texas. She's written a lot and taught and is a wonderful clinician. I was interviewing her about, a group had approached me about developing a new, built-from-scratch hospice facility, and I said, Kathy, you've worked in those facilities. What should I tell them? What should they not forget? And she said, Ira, tell them to get one of those big tubs with a hydraulic lift. It's essential. She says, often when I work the night shifts with the nurses' aides, we would bathe people just for their comfort and because it made them feel so good. We'd start with any patient who was agitated, and so often they would just become calm as we lowered them down into the water. We would gently wash them, and then we'd swaddle them in warm towels, and before putting them back to bed, we'd rub oil on them and love them up like you would a baby. It worked much better than the midazolam. So here are some of the forms of loving care that you're probably familiar with, but we don't name it that. I'm just putting it in a framework and giving it a label. Things like massage. In our service, we use Reiki quite a bit. Aesthetic grooming, hair and nails, brushing people's hair. We have now coupons. We have some estheticians in our region that will donate a certain amount of hours to us a month, and we can give people coupons to cash in, basically, to get their hair and nails done in the hospital. Storytelling and life review. We have our No One Alone volunteers who can help people tell their stories. Things like cooking, things like music, art, play. These are, a number of these, notice, are the complementary therapies, or prayer obviously is a spiritual care. But I think it can be understood as a way of conveying genuine love. Ritual and celebration can also be loving, as they were for Harry and Darlene. Kubler-Ross loving a patient. My nursing colleague Andy Dreiling loving a patient. These are familiar, aren't they? This is what we do. It's not unseemly. It's not trivial. I think we think it's just a nicety. This is part of human caring. Here, in our center, a patient receiving a massage. A patient in the infusion suite in the cancer center receiving Reiki. This is a quote. "I love those extra services, especially massage and Reiki. It makes me feel safe and well taken care of. It also sets DHMC," that's the name of our center, "apart." We employ part-time a visual artist to work with patients to express their feelings in art. This lady created a picture of a place that for her is a place of tranquility, and she had that in her hospital room. Margaret Stevens, harpist, playing on Friday mornings for inpatients at Dartmouth Hitchcock. A sand tray as one of the services that we provide as a workshop for patients. These are ambulatory patients. And here, this is Claire Wilmot, now a long-term survivor, thankfully, of acute myelogenous leukemia. Claire happens to be a friend and a surgeon from Littleton, New Hampshire, but she spent 4 months in the hospital going through a succession of failed transplants, stem cell transplants, until finally one, thankfully, has taken. Here's what she wrote, unsolicited. Marv is our creative writer who works with patients, came and pulled a few poems out of me and assigned me homework. He and I will submit poems to an international symposium on poetry and its place in healing. This is a surgeon saying this. Sorry, Val, I understand that surgeons have feelings. I thank you for the foresight and ability to run such a program. My symptoms are all manageable, and she had many, in large part due to the creative forces you have here. So as we begin to wind down, let me turn our attention to the communal aspects of the ethics of loving care. Harold Vanderpool, in an article called The Ethics of Terminal Care, said years ago, being part of a community is essential for the development of consciousness and individuality, and is characterized by communication, mutuality, and the ethical ideals of of fidelity, gratitude, reciprocity, justice, and love. He continued, he didn't continue. He did continue, but I'm not going to show you that. I want to switch to Henri Nouwen, who said, our society suggests that caring and living are quite separate, and that caring belongs primarily to professionals who have received special training. Although training is important, and although certain people need preparation to practice in their profession with competence, caring is the privilege of every person and is at the heart of being human. He said, we shouldn't try to care by ourselves. Care is not an endurance test. We should, whenever possible, care together with others. It is the community of care that reminds us that the dying person of his or her belovedness. Writing from a Jewish tradition, Lori Zoloth-Dorfman, clinical ethicist, has said, cleaving to one another, recognizing that the other is the bone of the bone and the flesh of the flesh that is given in common, locating the mutual body as the site of the moral gesture is fundamental to ethical reflection. It requires a radical rethinking of all that occurs to the other. All of the yearning, all of the loss is in fact my loss. That each of us will die is inevitable. What must come to be understood as miraculous is our ability to love and bear the weight of dying in fellowship. And finally, Hervé de Rocher. Now, I met Hervey when he was dying in the hospital of pancreatic cancer. He had had a successful career in accounting, from which he had retired in his 50s to pursue his real love of farming. He had a family farm in southern New Hampshire. He knew when I met him that he was approaching the very end of his life, and his goals were now clear. He said, "I want to get back on my tractor." We readily recognized it was a metaphor, Hervey's way of saying, "I want to be home." His wife, Joan, proudly described her husband as a strong, gentle man who was always there to help others. She assured me and our team that they could manage at home and that there would be plenty of help from neighbors and friends. So within a day, we got Hervey home with the help of a hospice program and their medical director, who was his private physician, Dr. Don McDonough, home to their rural community in southern New Hampshire. And within a few weeks, just a couple of weeks really, he had died. One afternoon, a letter arrived at my office at the hospital from Hervey's wife, Joan, with a card, this card, from his memorial service, and a request that I give her a call. On the phone, Joan described for me the funeral at the local Congregational church. She said that as the funeral procession wended its way from the church to the cemetery through the rural farmlands in southern New Hampshire, every field and salt box farmhouse they passed, every piece of land had tractors turned toward the road, lights on, in silent memoriam for Hervey, who they had lost. Loving care is part and parcel of a community acting in the most human ways to care for one another. In conclusion, I believe loving care represents an ethically sound set of responses to not only to suffering, but a therapeutically rich way of improving comfort and quality of life for people who are facing the end of life. In the care that we provide in healthcare, certainly the care we provide in hospice and palliative care, we need to reflect the inherent dignity of human beings. We need to be aware of our boundaries of professional practice, but we need to expand our ability to respond to people, not only through evidence-based medicine and the very best that science and technology and pharmacology have to offer, but we also can look at how we can care in the best ways, learning from our colleagues in pediatrics, to care with tenderness and unabashed love to the people we meet as patients. In so doing, I believe we can actually advance the profession of medicine and nursing and all of the clinical professions of healthcare, social work, chaplaincy, the physical and occupational therapies, all of that. And we can really leave to the next generation a model of human caring that is consistent with the highest values and reaches the real fulfillment of the human condition. That's what I think our opportunities are in the future. I thank you all for allowing me to share these thoughts with you, and thank you all for the work that you do. Thank you.
Thank you very much. Questions?
Or concerns?
This side.
Yes. Yes, sir.
Undoubtedly, current medical frameworks and practices can be problematic. Also, obviously, palliative care and loving practices are vital contributions to human care. But what bothers me, and by way of analogy, I would suggest this has been shown to be true in cases dealing with poverty or racism or addictions and many other fields, is that the problem of displacement, namely, as you deal with these particular problems, it lessens discussion of other equally, if not more important issues, like the shortage of resources, How much is society prepared to pay for first-class care? It doesn't deal with problems of prejudices, whether it be ageism or racism or classism. And so that I would suggest that if tomorrow we adopted on a wholesale level the kind of recommendations you're making, undoubtedly it would be marvelous for some individuals, but collectively I would suggest it would lead to greater deterioration of our present system. Because unless you deal with the real structural problems, all of this other stuff, unfortunately, becomes window dressing.
I actually disagree with the final point that you made. Clearly there is competition and many, many problems, and we're going to have to walk and chew gum at the same time. But in fact, the current structure does need to change dramatically. In my country, we don't really have a healthcare system. We have a disease treatment system. And clinicians, and including the students and physicians in training that I train, they love their patients. That's a human impulse. They can't, but it comes out in providing the next treatment for the disease. They don't know what else to do. So if somebody's dying, well, we'll find a clinical trial for you. We'll put you on dolbutamine for your, congestive heart failure. Maybe we can get you to an LVAD, one of these devices. Maybe you can have a liver or a kidney transplant or a heart transplant. It's misplaced. And in fact, that loving impulse, which I think is pure, is filtered through a system that doesn't provide healthy expressions. It only provides the next treatment. That's extraordinarily expensive. Right now, 20% of American deaths occur in hospitals. Occur in ICUs. 20% of Americans die in ICUs at $10,000 a day. Nobody really wants to die in an ICU, but they don't have alternatives that we provide. We don't have a care system, so that's what happens. So I actually think that if we were to do this tomorrow, we would find that first of all, the system wouldn't collapse, but it would be reshaped in a way that counterbalanced this sort of prison of technical mercies that we find ourselves in.
Okay, all I'm asking is, by all means, I agree with what you've said, but I'm just asking, how does one prevent the discussion replacing other equally important issues, which is one of the dangers? In other words, if you can do what you're suggesting in addition to the other things, it would be marvelous. Right. What I'm concerned about is what happens if it's done instead of other things.
Yeah, I hear you, and that is a danger, that we can't retreat from the best care possible or the best treatments possible to give the best care possible. We have to do both, and I think we have to continue to advocate for patients and families for access to services and quality of care. I find that this notion of patient and family-centered care is often very helpful to sort of keep us focused on what's really advances the well-being of people. And I think, although I'm very proud to be a physician, I think we need to look for nursing leadership a bit more than we have, because the nurses seem to get it and aren't in any way resistant to technology, but they understand that the human caring around which technology has to be brought to service. But thank you for your concerns. I think they're real.
Oh, next question, please.
Ira, thank you so much.
Tom,
and
please.
I want to acknowledge what a wonderful job you did. I mean, I came into the talk tired a little bit. I go out of it energized, kind of re-inspired, agreeing with everything, but re-inspired, kind of a fire lit. My question is, how do you keep that fire lit so that it can light other fires? Because it is challenging sometimes. Can you tell us a little bit, how do you do that for yourself, and how do you do that for the people around you?
I can only say that this notion that we're a glass, and if we spend our compassion and our passion, we become empty, and that we can leave ourselves empty and devoid of compassion fatigue, I think is a metaphor that's misplaced. what keeps me going is I continue to care for patients. I'm active clinically, and that also fills me up. I get so much, this sounds like a cliche, and for those of you who aren't clinically active, it may sound like just a cliche, but my experience is that I am energized by the care of patients, by the love that I have for people. And so, it keeps me energized. It also, frankly, sometimes my energy comes from being angry, frustrated by the constraints of the health system, seeing things that I wish were different and things that I want to change. But that, too, is an energy that I can often direct toward constructive avenues. But I think at the core of it is that I'm a clinician. I'm not an ethicist. I'm not even, I'm not a philosopher. I do this because I know what's possible, and I can sometimes too often see what I can't do, or how the system fails patients, when I can imagine other things we could do to improve people's quality of life, their family support during this time. That's what I think energizes me most.
Well, thank you, and I'm grateful that you're here today to share it with us.
Thank you so much, Tom.
Others? Yes, one.
I've read your frustration and I know it, but it just occurred to me, how could we start this off as little children and develop it in ourselves, so when we get to the stage where we have the power to do it, we could do it.
The reason I tell stories and the reason I teach is that it's the only ways I know of conveying this notion that there are things to be done, that the end of life, so often people assume that the end of life is all about suffering or its avoidance. Well, let me tell you, it's risk-filled, and there's plenty of risk of suffering, and I don't want to glorify any of this. But it also is true that the human condition still has so much opportunity, and can be even the saddest times can be so rich and enriching. So we have to show our students, show our children that this time of life is also part of full and even healthy living. Whew. I'm not selling this, but my first book was called Dying Well, and I chose that title very carefully. So when you hear Dying Well, I was told by my publisher you should call it a good death. Ugh. Don't know anything about death, and death's a lifeless state. Never been there, never been convinced I met anybody who knew anything about it. I wrote Dying Well. Well, when you first hear it, is an adverb that modifies or describes the dying experience, right? Dying well. But it's actually more provocative to hear the word well as an adjective. Can a person die well? Can a person be well within themselves as a human being, even though they are mortal and that their body is dying? Well, of course they can. But the only way I know how to show that is to tell stories, or to take students with me on rounds and consultation to see real people who are obviously well during the time that we would consider them to be dying.
I worked with a medical student, and she came one day on bus. She saw me, and she thanked me for what I had taught her in that training. But I thought it was sad. She's at that stage of life before she died.
It is sad, but that's the work that we all have to do. Everyone here, certainly everyone in this wonderful young field of palliative medicine, this is part of the work that we have to do. We are leading the culture, and it's part of the historic challenge and responsibility of a profession to provide leadership to the society of the time in our realm of expertise. Part of our role, I would assert, is to help society grow the rest of the way up. Right? We boomers need to grow the rest of the way up. We're mortal. We're going to die. Get over it. And let's get on with living fully, richly, joyfully in whatever time nature or God gives us. That's part of full and healthy living. In a sense, love for one another at the end of life is a defiant and creative act. We are saying to one another, we matter. You know, it's like defiance of the force majeure. You may take away our life, but we matter to one another. That's part of the cultural maturation that I think we have a chance to foster. Thank you all again for having me here to this wonderful lectureship.
Don't go away yet. I have 3 short tasks. The first is to express our gratitude to Frances Morris, without which these events and many others would not occur. She is the keeper of the Palliative Care Council. Secondly is to remind you that there will be a reception outside, and we hope that you can all stay. And third, we bring out as many superstars as we can to match superstars when they come. We've already had Neil MacDonald, and now I would like to ask Val Mount to thank the speaker on our behalf.
No, you have to stay here. I just wanted to say that as you go out, you'll be given your group discussion number, and it starts tomorrow morning at 8 o'clock. And it's 3 days, I think, this workshop. Isn't it wonderful to have, to be challenged and to think about old topics in new ways? And Ira, you reminded me that there are always fresh ways to look at. Well, Dick said it well in introducing you when he said that every time he hears you speak, it ends up coming back to ourselves. And when you speak about loving and caring and being present to each other, we're talking about health care, but we're really talking, as you've just reminded us, about how we live in all our relationships, and I thank you for that. In his writing The Critique of Pure Reason, Immanuel Kant in 1781 said, "Science is organized knowledge, but wisdom is organized life." And Ira, you've reminded us of the need to celebrate both science and life. And it's been a very rich time, and we want to thank you.
Thank you very much. Thank
you. We have a little reminder of our time together. We'll remember you. Here's something that
I'll never forget it.
Help you remember us.
Thank you very much.
Thanks.
Don't cry. Thank you all.